Good evening, everyone. Thank you for joining us for another webinar tonight, brought to you by New York Gastroenterology Associates. I am Dr. Janie Yang. I will be moderating the webinar tonight. Tonight, I have the pleasure of introducing two experts in the field of liver medicine and nutritional science, who will help us to understand this challenging medical condition called NAFLD, or non-alcoholic fatty liver disease. Our first expert is one of the newest members to the NYGA team, Dr. Jennifer Liang. She is a board-certified gastroenterologist and transplant hepatologist, a specialist in liver medicine, as well as a diplomat of the American Board of Obesity Medicine. Dr. Liang joined us from Mount Sinai, where she has been serving as an assistant professor of medicine for 11 years. She completed her medical degree and residency training at NYU, a GI fellowship at North Shore University Medical Center, and a transplant hepatology fellowship at Mount Sinai. On a personal note, she was my very first teacher in liver medicine when I was a brand new medical school graduate working at Mount Sinai as an intern. So it's a real pleasure to now call her my colleague. Our second speaker tonight is Susie Finkel, who has joined us for a few of these webinars now. She is a GI specialized registered dietitian who works with patients on dietary management of digestive symptoms and diseases. She holds a Master's of Science in Nutrition from Columbia University. In addition to patient care, she is part of the NYGA's Inflammatory Bowel Disease Research Team, a guest lecturer at Columbia's Graduate Nutrition Program, and a clinical preceptor for dietetic interns. She also enjoys sharing evidence-based nutrition information as a digestive health writer for a variety of online publications. Before I turn the microphone over, a few housekeeping matters. The webinar will be recorded and posted on our NYGA website, where you can find recordings of our previous webinars as well. Please use the Q&A function to submit questions, which I will help to address during the webinar. And we will try to answer and discuss as many questions as possible at the end of the webinar as time allows. We aim to conclude this webinar at 7:30 p.m. Okay, without further ado, let me turn it over to Dr. Liang.
Thank you so much for that wonderful introduction, Dr. Yang. And might I add on a personal note, it was a pleasure working with you as well. And I'm very pleased to join you as a colleague. And thank you all for joining us tonight for our webinar titled Baffled by NAFLD, the Facts About Fatty Liver. So I will add in a disclaimer here that despite all the knowledge we have gained about fatty liver in the past few years, there is still a lot about it that remains unknown and controversial. So much so that even the name of the condition is being debated at this time. However, we won't be going into that tonight, and we will just focus on the basics. So what is non-alcoholic fatty liver disease? We also will call this NAFLD, and I will interchangeably just use fatty liver. So this is a condition in which too much fat is stored in the liver cells. The liver is not meant to store fat. This is really the role of the body's fat tissue, also known as adipose tissue. It is defined by the presence of greater than 5% of fat in the liver when no other causes for secondary hepatic fat accumulation is identified. And here you see a healthy appearing liver at the top, and to the right of that, you see all that yellowish hue, that is fat depositing in the liver. Historically, this was thought to be a benign condition, but in the 1990s, it became increasingly recognized that fatty liver was a serious medical condition with associated morbidity and mortality. And it was found that this disease can progress and lead to cirrhosis and other complications, such as liver cancer. At the bottom of the slide, you can see what a piece of liver tissue would look like histologically under a microscope. You can see the normal healthy liver cells on the left, and on the right, you see fatty liver, where you see fat droplets depositing in the liver cells. So let's give you some statistics. This is a condition that is seen worldwide. It is the most common liver disorder in Western industrialized countries, including the US. It is currently estimated that about the global prevalence of fatty liver is about 25%. And in the US adult population, it affects about 25 to 30%, with some studies even reporting up to 46%. That comes out to, in absolute numbers, about 80 to 100 million of adults in the US affected with this condition. Both the prevalence of NAFLD and the stage of liver disease appear to increase with age. It is a major predisposing factor for primary liver cancer. And it is also currently the second most common indication for liver transplantation in this country, and it is on track to becoming the leading indication. Given the growing prevalence, it's also becoming a growing problem in the pediatric population as well. So what is the natural history of fatty liver? Let's talk about the umbrella term first of non-alcoholic fatty liver disease. This is actually a spectrum that encompasses different stages in the disease. So first we have NAFLD, N-A-F-L, which is just fat deposition in the liver without inflammation or scarring, also known as fibrosis. About 40% of these patients can progress to what's called non-alcoholic steatohepatitis. This is characterized histologically, meaning that we need to take a sample of the tissue and look at it under a microscope, by the presence of inflammation and cellular injury. There may or may not be fibrosis, also known as scarring at that point. As the disease progresses, as your liver starts to get damaged, it tries to repair itself by creating new healthy tissue. If the damaging process continues, the liver's ability to create enough healthy tissue and to clean up the damage that has occurred may be exhausted, and as a consequence, you start to develop scar tissue, and this will accumulate. The scar tissue is called fibrosis, and then you start progressing to the stage of which we call fibrotic NASH. And as the disease continues, you then develop NASH cirrhosis, and ultimately you can end up developing liver failure. And as you can see along the spectrum, as the disease progresses, the risk of liver cancer increases as well. So what are the liver consequences? So on a brighter note, despite all the potentially dire consequences that can happen, the majority of patients with liver disease who have fatty liver will actually remain stable or have slowly progressive disease, and it will not result in cirrhosis or liver-related death. Again, going back to that natural history slide prior, about only 30 to 40% of those who just have fat in the liver without inflammation, without scarring, will develop inflammation that we call NASH. A proportion of these, 40 to 50%, will develop fibrosis, and about 20% of patients will actually develop cirrhosis. These numbers are they're just estimates. Unfortunately, the natural history of this disease is still not fully well understood. We don't really have a lot of great long-term studies because the disease does tend to be slowly progressive. The stage that we worry about is really NASH. NASH, again, is that stage where you have the inflammation and the fibrotic NASH when you have fibrosis. But NASH alone will increase the risk of liver-related mortality by 5 to 10-fold. And again, as the disease progresses, the risk of developing primary liver cancer, otherwise known as hepatocellular carcinoma, which I put here as HCC, it is nearly double that than from the general population. So you have an annual incidence of about 0.5 to 2.6% among those people who have cirrhosis. About 40 to 50% of these liver cancer cases that arise from NASH can actually arise in those who don't have cirrhosis. Typically, these are people who have advanced scarring. Fortunately, the incidence of this is much lower. Are there non-liver health consequences? So when we talk about fatty liver, everybody's always worried about what's going to happen to their liver, but what about the rest of the body? Does the fat in the liver or the inflammation that can occur with it start to affect other organs in our body? So there has been, so the relationship between fatty liver and all-cause mortality is somewhat unresolved. There are some studies showing a modest increase in the risk of all-cause mortality compared with the general population. And then there are others reporting no association between fatty liver and increased mortality. That being said, cardiovascular disease and extrahepatic malignancy are the most common causes of death in patients with fatty liver overall, followed by liver disease. Fatty liver does increase the risk for cardiovascular disease because it influences the buildup of atherosclerosis. It causes damage to the heart. It nearly doubles the risk of developing cardiovascular disease compared to those who don't have fatty liver. In terms of malignancies or cancers, there's a 1.9 times higher risk of incident cancers than the general population, particularly cancers involving the GI tract and the uterus. And there's now more data showing that there is fatty liver is associated with a twofold increase in the risk of chronic kidney disease. The mechanism and pathogenesis of this is still not fully understood, unfortunately. What about diabetes? Oops, sorry. So fatty liver and type 2 diabetes. Type 2 diabetes is one of the most important factors for the development of fatty liver, the progression of the disease itself, and the development of liver cancer. But what does fatty liver do to type 2 diabetes? It actually, the relationship between the two is bidirectional. Fatty liver actually does worsen insulin resistance. It is associated with a 2 to 5 times increased risk of incident diabetes, and it actually makes type 2 diabetes more difficult to manage. And what about the effect of type 2 diabetes on fatty liver? Type 2 diabetes increases the risk of having NASH. It increases the risk of disease progression to cirrhosis, and it absolutely does increase the risk of liver cancer as well. So this slide is really just to show you how complex the pathogenesis of fatty liver is and all the multiple factors that can impact the disease and its progression. So you can see here in the first column, you see all the different comorbidities, such as obesity, metabolic syndrome, insulin resistance, type 2 diabetes that we just discussed, high blood pressure. Those have been shown to have definite effect in driving NASH progression. There are genetic markers that are being identified. There are microbiome products that also affect the disease. And then there's, importantly, nutrition and behavior, where you can see alcohol, high cholesterol driving the disease progression. Exercise and coffee, fortunately, have been found to be productive. But again, what you can see is that this is just a really complex disease, and it's more than just saying that it's just about fat depositing in the liver. I just wanted to touch a little bit on lean NAFLD. So it is not, fatty liver does not just occur in those with a BMI of 30 and above. It is seen in up to 80% of people with a BMI of 30 and above. However, it is seen in people who have a BMI under 25 or under 23 for Asians. It does account for about 7% of the fatty liver cases in the US, and it can range as high as 19% and even in some studies up to 20 or 30% in Asia. These patients are typically of Asian or Hispanic origin. The outcomes for lean fatty liver versus those with a BMI above 30 or more remains controversial. There is some data to suggest that those with lean fatty liver have a more aggressive histology, but other literature conflicts this, saying and actually shows that these patients are less likely to have NASH or advanced histology and may also demonstrate less hepatic steatosis. More than likely, there's a lot of genetic influences that play a strong part in this population and their outcomes. So what are the signs and symptoms of fatty liver? Most often patients are asymptomatic. There are not many pain sensors in the liver. However, some people may come to attention because they may have some right upper side abdomen discomfort. They may have this vague feeling of fullness there or a little bit of pressure. Sometimes that's due to pressure on the capsule of the liver where the nerves run. Sometimes they can be found incidentally when you go for a routine physical exam and your doctor does blood tests and you see elevated liver enzymes. But importantly, up to 50% of people with fatty liver can have normal liver enzymes. So unless you have a high suspicions of this, the diagnosis can be easily missed. We talked about having the right upper quadrant discomfort. You may palpate an enlarged liver on exam or see an enlarged liver on imaging studies. And actually fatigue and malaise. This is now being increasingly recognized as a symptom of fatty liver, independent of any other conditions that may be contributing to fatigue and malaise. In those with advanced disease, they may be jaundiced or icteric, meaning that your eyes and your skin may start to yellow. You may have diffuse itchiness. There may be swelling and distension in your abdomen or legs with fluid buildup or swelling. And these are typically signs of more advanced progressive liver disease, not something you would see in the early stages of fatty liver. So how do we diagnose fatty liver? So typically it's a diagnosis of exclusion if not made by liver biopsy. And if you're not making the diagnosis by liver biopsy, you either see this, you typically then will see the steatosis, the fat in the liver, by imaging with an ultrasound or a CAT scan or an MRI. And again, you really want to exclude any secondary etiologies of hepatic fat accumulation. There are many other things that can cause fat deposition in the liver, such as alcohol. This can mimic fatty liver. There are medications that can cause fatty liver, and there are even other liver diseases that can cause more fat to deposit in the liver. So you always want to evaluate for these things and rule these other potential conditions as well. Again, your doctor will do blood tests, and importantly, again, up to 50% of patients will have normal liver tests. We talked about the imaging studies. Typically, you'll start with an ultrasound. The liver may appear fatty. A CT scan will also show a fatty liver. Ultrasound and CT scan are pretty sensitive for picking up fatty liver. However, it doesn't tend to pick it up until the liver has about more than 30% of fat, which is considered grade 2 fat in the liver. Other scans, such as a fiber scan or a Velacure scan, for those of you who have been in the office with us, these are scans that we perform in the office. These scans do not provide, can actually provide an estimate of how much fat is in the liver, and can actually also estimate the degree of scarring or damage that's in the liver. And then, of course, there's the MRI, which can also do the same thing. It can quantify the amount of fat and assess the degree of scarring. So these last few tests are great substitutes for liver biopsy. The only thing that they cannot do, however, is that they cannot tell you whether or not there's inflammation going on in your liver. That is something that you can really only discover with the liver biopsy. So this slide just shows you the fiber scan on the left and the images that we end up pulling up. And then on the right is the Velacure scan, where we just both scans, the ultrasound probe is put up right against the side of your rib cage. There's no needles involved. It's just feel a little pressure, a little bit of tapping on the side of your rib cage when the machine is sending ultrasound waves through to, again, try to measure how stiff your liver is as a surrogate marker for scarring, and also to see how the waves get attenuated as a consequence of having significant fat in the liver. So now that you've been diagnosed with fatty liver, how do you treat this? Really, unfortunately, there are no currently FDA-approved medications that target the treatment of fatty liver disease. Really, cornerstone of therapy is really all about lifestyle modification. We focus on weight loss, healthy eating habits, maintaining an active lifestyle, diagnosing and managing any comorbid features of metabolic syndrome, which includes diabetes, high cholesterol, hypertension. You want to abstain from smoking. There have been studies that have shown that smoking does increase the risk of fibrosis, so scarring and disease progression. And actually the number of cigarettes actually has been shown to correlate with the also with increasing risk of fibrosis stage as well, and minimization and abstinence from alcohol intake. Let's just touch briefly on weight loss. Here's the thing about weight loss. Although there are a lot of studies that have shown this data, and a lot of guidelines right now will tell you, okay, this is what we need to do to get reversal of disease, prevent disease progression. The studies have shown that about 7 to 10% of total body weight loss has been shown to result in resolution of the fat in the liver, resolution of the inflammation, and even fibrosis regression. So the important thing to know about fatty liver is that if you take charge, if you start to target the things that are putting you at risk for fatty liver, you can not only halt disease progression, but sometimes you can even get reversal. So 7 to 10% total body weight loss, this is what you may be hearing quoted time and time again. You may hear this from your doctors. And even you don't necessarily even get to that 7 to 10%, even 5% of total body weight loss can result in a reduction of your liver enzymes, triglycerides, A1C, and your risk of developing type 2 diabetes. But I think the important thing, and when you think about the weight loss, is how do you get there? And is it really necessary to have that resolution in fatty liver, as well as the inflammation and the reversal of fibrosis? What are the benefits of exercise? So this slide comes from the physical activity guidelines for Americans. And what you can see here in this graph is that as you start to increase physical activity, you start to see health benefits that are practically immediate with just increasing physical activity. You can see an improvement in anxiety, blood pressure, improved quality of sleep, and insulin sensitivity. You see that the relative risk of all-cause mortality continues to decline as people become even more physically active. Most of these benefits are attained with at least 150 to 300 minutes of moderate physical activity per week. And what we define as moderate physical activity is something like brisk walking, not even asking you to go do intense running or doing a high impact cardio class. Similar data was actually found in a longitudinal study from the National Health and Nutrition Examination Survey, which looked at over 2,700 individuals with fatty liver. And it also showed that with increasing duration of physical activity, this was associated with a lower risk of all-cause mortality during an average follow-up of about 11 years. Even more recently, a meta-analysis study that was published last month showed a clinically meaningful response in liver fat independent of weight loss in participants who received exercise training. So those who performed an exercise dose of over 750 metabolic equivalent tasks per week resulted in significant treatment response with a 30% or more relative reduction in MRI measured liver fat. So what does that mean? So a 30% reduction in MRI measured liver fat is actually the threshold required for histologic improvement in NASH activity, NASH resolution, and liver fibrosis stage. And again, going back to what does that 750 metabolic equivalent task translates to at least 150 minutes of moderate intensity exercise, again, which brisk walking qualifies as, or 75 minutes per week of vigorous intensity exercise, such as jogging or cycling. So moving on to what should you eat next? And I'm going to hand the microphone over to Susie for this part.
So when we're talking about managing metabolic conditions like NAFLD, I'm going to say NAFLD because I just find it a little bit easier and faster, but non-alcoholic fatty liver disease. There's lots of acronyms in this practice. But so when we talk about treating NAFLD and type 2 diabetes with diet, one of the things that's really important to discuss is what the significance of body weight is. And we can progress to the next slide, Dr. Liang, because that'll sort of have the nutrition team here at New York Gastro, sort of our perspective. It's really helpful when we talk about the difference between just focusing on weight and behavior changes. And I just want to start by clarifying that weight and metabolic health are not synonymous, although there's this tendency to think of them as the same thing. And along those lines, nutrition and body weight are also not synonymous. A lot of people have this tendency to conflate the two. And when we're treating metabolic conditions, we're not simply focused on reducing a number on the scale, or if we're helping someone to make diet changes, the goal is not to see weight loss per se. It's to really look at, how they're implementing some of these dietary changes and what their eating patterns look like. And that's really the nutrition team's approach here. We use this weight inclusive model, which means that everyone can achieve better health and well-being independent of your body weight by focusing on health promoting behaviors rather than the number on the scale, because we see that one's diet and lifestyle practices are what affect health outcomes, right? Metabolic outcomes, not body weight alone. So why do we place the emphasis on changing behaviors instead of something like weight loss alone? Because the research shows us that adopting certain dietary habits, which I'll review in a bit, and getting regular exercise, which Dr. Liang has touched on, has been shown to improve metabolic disease, even when it's not accompanied by weight loss. Sometimes it is, and sometimes it's not, right? A meta-analysis, which is essentially a study of studies, which included 316 people with NAFLD concluded that people engaging in regular exercise had improved liver enzymes, improved LDL cholesterol, improved triglycerides, even without a significant weight loss. And multiple review studies, which are like research summaries of research essentially, found that regular exercise, even without weight loss, also may reduce liver fat by 20 to 30%. And it's also been shown that long-term adherence to healthy diet changes can maintain liver benefits, even in patients that had weight that was regained after the fact. And so that kind of suggests that the behavior changes that drove initial weight loss may be responsible for much of the benefit versus the weight loss itself. The reality is that people of all body sizes are affected by metabolic conditions, and that can be addressed with lifestyle changes and often needs to be addressed by lifestyle changes. So, the notion that people in larger bodies get diabetes or get NAFLD is false. And we know that as healthcare providers, we see a range of patients, in different body sizes that are affected by these conditions. And we also know it from the research. There's a study of 18,000 people examining the presence of NAFLD, and it showed that, quote, lean women with NAFLD were at a higher risk of developing metabolic syndrome than people with NAFLD at a comparatively higher body weight. And when it comes to type 2 diabetes, a very large representative population-based study showed worse blood sugar control among people in the, quote, normal BMI category compared to higher BMI categories. So I just point out some of this data to say that there are some false assumptions that can be made about the number on the scale, right? Just this number alone. And we want to reshift that focus to the behaviors that have the biggest impact on our actual health outcomes. So a question, patients often ask is, well, I want to lose weight. What's wrong with that? And the answer is, we're not really here to tell you whether it's right or wrong for you to want to lose weight or to gain weight or to, really do anything that could potentially impact your body weight, as dietitians. But as weight inclusive practitioners, we are going to tell you that weight loss is not a direct control behavior. It can and often does accompany behavior change, meaning diet and lifestyle changes, but it's not guaranteed for everybody. And we're just going to accept, and we have to accept, that that's okay. Weight is not our sole measure of metabolic health. It is, something that we can be mindful of. And when someone thinks that it is, meaning that there's a hyperfixation on this number on the scale alone, they can engage in diets to try to lose weight that can actually worsen our cardiometabolic risk factors. And we see some extreme forms of diets, like, keto diets with tons of animal protein and no, healthy carbohydrates, and long fasting periods of people who are skipping breakfast and eating only at night, and then very low calorie diets, even with foods that could potentially worsen these conditions. If you're a patient of mine with metabolic disease, you've probably heard of my extreme, like, gummy bear diet example, just to sort of illustrate what this looks like. But you could, eat gummy bears every single day as your only intake, and maybe it's an even small amount of gummy bears. You're eating very few calories in the day. And I mean, it's possible that that patient could lose weight by way of starving themselves eventually. But the question would be, did they improve their metabolic health? And that could have some pretty serious negative outcomes for fatty liver disease, for example, for blood sugar control. So sometimes there's, calorie counting involved, or there is food restriction involved, simply to try to get a number to go down on the scale. And sometimes that number doesn't even go down on the scale. And if it does, it doesn't mean that we're bettering our health because of it. And so, there's there's this distraction that can happen when we're really just focused on weight loss. And we see people adopt these unsustainably restrictive diets all the time and then regain weight that was lost or more weight in the end. And these can be metabolically harmful over time. It results in these weight cycling scenarios, as well as some pretty serious, damage to food relationships, which can turn into disordered eating, into diagnosable eating disorders. And so we really, caution against those roots. And, on the flip side, those that do adopt healthy behavior changes, but are still really focused on losing weight alone, may feel like a failure if the new diet or exercise regimen that they've adopted doesn't result in a goal weight, or they're not seeing the number go down on the scale, and they might just abandon those really healthy changes. They're really doing good things for their health, but not kind of able to see that because it's just this sort of tunnel vision. And so I'll just say again that changing your lifestyle and habits for the long term improves metabolic health, regardless of whether or how much weight could be lost. So I want to share 2 examples of metabolic health scenarios just to kind of highlight what this could look like and the difference between a weight-centric and a weight-inclusive approach. So first, let's just see what this looks like for NAFLD. In a weight-centric approach, we often see healthcare providers telling patients to lose weight to improve their liver function. In a weight-inclusive approach, the provider would say something like, there are a lot of data showing that diet change is the primary treatment to manage NAFLD. Would you like to meet with a dietitian to talk about the therapeutic dietary treatment for fatty liver disease? With that model, all people would receive the same advice regardless of their body size. And as I've noted before, weight loss might accompany healthful dietary change. And even if it doesn't, we know that there's a set of dietary changes that can improve your liver function regardless of what's going on with a body weight number. And one way is through changing your dietary pattern and eating times through the day. It's actually not good for your liver to eat very little during the day and get most of your energy at night, which we see lots of patients doing. And so modifying this can be helpful even if you eat the same amount in total all throughout the day. We're really thinking about the timing of the food intake. Overall diet pattern, we'll sometimes refer to it as an anti-inflammatory diet. It often gets called in the literature and in media as a Mediterranean diet or Mediterranean style diet. I tend to not use that word because people envision something very specific to certain regions of the world, but it can look like a lot of different things across global cuisines. And that's a dietary pattern that it can improve your liver function by way of eating more fiber-rich carbohydrates, plant foods like legumes and beans, non-starchy vegetables and fruits and whole grains, and eating less of the bread, white rice, potatoes, chips, sweets and sugary foods as the main part of the meal. We also know there's proven benefits to including foods high in unsaturated fats like fish and avocado and nuts and olive oil, and reducing saturated fat foods or foods rich in saturated fat like red meat and higher fat dairy foods. And there's even a benefit of regular coffee drinking, which is everyone's favorite to hear for adults. That's been shown to have a protective benefit against the progression of NAFLD, and engaging in regular, hopefully joyful movement, some forms of exercise, definitely helpful for this as well. So in another example for type 2 diabetes, in a weight-centric approach, we often see healthcare providers telling patients, kind of simply to lose weight and cut out carbohydrates entirely to improve blood sugar control. In a weight-inclusive approach, the provider might say something like, diet and meal patterns have been shown to significantly improve blood sugar control and can impact the progression of the disease. Would you like to meet with a dietitian to talk about therapeutic dietary treatment for diabetes? And with this model, all people would receive the same advice regardless of the size of their body. And examples of these changes include things like choosing lower glycemic or slow carbs to help avoid blood sugar spikes. It includes higher fiber choices, resistant starches, which involves heating and then cooling and then potentially reheating that starchy food, and substitutions for very sugary foods. These could also include food pairing, which involves balancing carb portions with non-carbohydrate foods like proteins to temper their blood sugar impact, and also increasing the balance of vegetables and fiber in meals generally. We also use a circadian aligned eating approach very often, which means front loading overall food intake and carbs to better align with your body's metabolism and kind of natural rhythm, or I should say the metabolism's natural rhythm through the day. And just a plot giveaway, that means not skipping breakfast and really, jump starting with a meal. And again, regular physical activity, that's customized to someone's ability, whether it's walking or dancing or something that hopefully brings someone joy. And I'll pass it back to Jen.
Okay, thank you for that, Susie. So here's a question I know you guys are all burning to ask tonight. Can I still drink alcohol? Susie touched on coffee. Let's talk about alcohol. So how much alcohol is safe? Significant alcohol consumption is defined as an average consumption of greater than 21 drinks per week in men, so about three drinks per day, or more than 14 drinks per week in women, so about 2 drinks per day over at least a 2-year period. Is there any amount of alcohol that's considered safe? The latest US recommendations are to drink in moderation by limiting intake to 2 drinks or less in a day for men, or 1 drink or less in a day for women on days when alcohol is consumed. So the important thing is, what is a standard drink? This is just to show you, a 12-ounce can of beer is a standard drink, not necessarily like the 24-ounce can of beer that sometimes you'll see in the liquor store. Sometimes when I go out, there's a very tall pour for that glass of wine. So really understanding what a standard drink is important. And this kind of just goes through all the different types of alcoholic choice beverages that you have. But really importantly, how does alcohol affect fatty liver? Alcohol absolutely can be an important contributor to fatty liver disease progression. Alcohol in and of itself can cause liver disease, liver cirrhosis, liver cancer, liver failure. And the studies have been shown that mild to moderate drinking has been found to increase the risk of NASH, fibrosis, progression to decompensated liver disease. It increases the mortality and, of course, increases the risk of liver cancer. Heavy alcohol consumption absolutely accelerates liver injury and fibrosis progression and should be avoided in patients with fatty liver and NASH. Patients with clinically significant fibrosis or cirrhosis should abstain from alcohol use completely. So if you don't have significant fibrosis, if you don't have any of those things, the question is always going to be like, well, can I have, how much can I really drink to be safe? And what I'm going to say is that at this point, there's really no defined amount of alcohol that is considered safe per se, that you can just generalize across the board. This decision really needs to be made on an individual basis. You have to take into account the person's presentation, their blood tests, any comorbidities. Again, you want to look at the stage of their liver disease, if there's a significant amount of fat. Alcohol, beyond just having these pro-inflammatory effects, also adds a lot of empty calories too. And I just discovered recently that a pint of lager has the same numbers of calories as a slice of pizza. So who knew that when you're having that pint of lager with your slice of pizza, you're actually having 2 slices of pizza. And if you're having that second drink, then you're now having 3 slices of pizza. It just starts to add up. So with alcohol, this conversation really should be had with your physician, and absolutely trying to minimize it as much as possible, if not completely abstain from it in certain situations, is is important and can help absolutely prevent disease progression. What about coffee? So Susie already touched on this a little bit, America's favorite beverage, or one of the favorite beverages. So just to touch on this a little bit lightly, since Susie already discussed this, coffee, the data on this is a little bit conflicting, but for you coffee lovers out there, coffee consumption has been associated with a lower risk of metabolic syndrome. Studies have also shown an inverse association between coffee consumption and liver fibrosis. So the more coffee you drink, the less likely you are to have liver fibrosis. That being said, I wouldn't recommend having tons of caffeinated coffee all day. Who knows what's going to do to your heart with palpitations. It does appear to also have a protective effect against developing liver cancer. In regards to steatosis, the amount of fat in the liver, the results are conflicting. There's really no good data out this time. And honestly, what I would say about this data with coffee, this data is mostly from observational studies. So there really hasn't been a true cause and effect that has been established, but it certainly hasn't been shown to be harmful. And at the very least, probably having some benefit in people with underlying liver disease. So what about potential therapies or drugs for fatty liver? As I mentioned earlier, there really are currently no FDA-approved therapies targeting fatty liver. There have been many clinical trials looking at many different medications and type of drugs. I'm only going to touch on a few of them, specifically vitamin E. This has been shown to have benefit in those without cirrhosis and those who don't have type 2 diabetes. Not to say that it negatively, that it doesn't help the type 2 diabetics, but the studies that looked at the benefit of vitamin E were done in patients who did not have diabetes. So typically, if you were to consider using vitamin E, the patient that it is recommended in is a very specific type of patient. It is patients who have biopsy-proven NASH and fibrosis stage 2 or more who do not have diabetes. The data has shown that it can improve steatosis and inflammation, but the data have been mixed, and there are some potential safety concerns with high dose vitamin E in that vitamin E has been inconsistently associated with perhaps a potential increase in all-cause mortality and potentially an increased risk of prostate cancer. So this should be used in a very specific population, and if consideration of this vitamin is to be used, you want to have that discussion with your physician. Another medication that has been shown to have some benefit is a medication called pioglitazone. This is a medication that is currently approved for patients with type 2 diabetes, and this has been shown to improve fibrosis as well as inflammation and steatosis. However, the use of this medication is also limited because it is associated with an increased risk of weight gain, heart failure, and fractures. So coming to the GLP-1 agonist. So this is the medication, class of medications that I'm sure many of you have heard about. There are tons of commercials for these medications for Ozempic, Wegovy, Mounjaro. These are all GLP-1 agonists. And we can talk a little bit more about that. So how do GLP-1 agonists work? Currently, these drugs are approved just for the treatment of type 2 diabetics and some for treatment of weight management. But these drugs mimic the action of a hormone called glucagon-like peptide 1. They stimulate the body to produce more insulin when blood sugar levels start to rise. They bind to receptors in both the central nervous system and the gastrointestinal tract, which reduces your appetite. So it suppresses hunger sensation and it delays gastric emptying. So people tend to feel full more quickly and feel full longer in between meals. So that helps suppress your appetite, and then people tend to eat less. None of them are currently approved for the treatment of NAFLD or NASH. However, there are many clinical trials currently looking at these medications in patients with fatty liver. Certainly there are ongoing studies right now, and there have been studies that have shown improvement in steatosis, resolution of NASH, and reduction in fibrosis progression. So stay tuned. There's going to be a lot more data coming out about this, hopefully in the next year, and perhaps these medications will hopefully provide the benefit that we need to see for our patients with advanced fatty liver disease. Moving on to bariatric surgery, I'm not going to touch on this too much, but bariatric surgery has been shown to be beneficial. It can resolve NASH. It has been shown to improve hepatic fibrosis. It does induce sustained weight loss of up to 30%, has been shown to cure diabetes, and it does decrease all-cause morbidity and mortality. So who should be screened? Universal screening is not currently recommending, even, it's still 25 to 30% of the general population, but still a significant proportion do not have it. But they do recommend that select risk groups should be screened. So those with type 2 diabetes, those with a BMI of 30 or more, those with 2 or more cardiometabolic risk factors, so people who are at risk for metabolic syndrome. This looks at waist circumference greater than 40 inches in men, greater than 35 inches in women, triglycerides of 150 or more, looking at your cholesterol panel, your blood pressure if you have hypertension, if you have diabetes or pre-diabetes or some signs of insulin resistance. If you have hepatic steatosis, if your liver looks fatty on imaging, and if you have elevated liver enzymes, then this is a group of people who should be screened for fatty liver. So in summary, NAFLD is increasing in prevalence, not just in the US, but globally as well. Importantly, if it's detected and managed early enough, it may be possible to prevent and even reverse damage done to the liver. The cornerstone of treatment as well as prevention is having a healthy lifestyle, which includes both healthy eating habits and making sure you're physically active. And there are non-invasive alternatives to liver biopsy to assist in making the diagnosis. So you don't always have to have that liver biopsy to make the diagnosis for this. And that concludes our discussion. Any questions?
All right, thank you for the wonderful lecture that you guys gave. So I'm going to open the floor. I have a few questions accumulated, so let me just get started. We have about 13 minutes to get through them. All right, the first one I have here is, what does, what is it? Hold on one second. Are there any correlations to gallbladder disease when it comes to fatty liver?
So there aren't correlations to fatty liver and gallstones specifically per se. It really depends on what your drivers of fatty liver are. So if you have unhealthy eating habits, if you tend to have high fatty foods and things like that, you can have an increased risk for gallstones, but fatty liver itself does not increase the risk of having gallstones or gallbladder disease.
Right.
Nothing that's been shown in the literature anyway at this point.
When you already been diagnosed with fatty liver, do you become more susceptible for getting other hepatitis?
So no, it does not increase your risk for developing other liver diseases. No, I think that's the simple answer. No, it doesn't increase that risk for that.
One of the things I mentioned is that if you already have fatty liver and you are exposed or got viral hepatitis, you may have a slightly worse reaction to it because your liver is already injured. So oftentimes when we diagnose people with fatty liver disease or some kind of liver issue, we do recommend them to get vaccinated so that to prevent future potential infections of viruses.
Yes, thank you for making that really important point. When you go to see your doctor and you're being evaluated for fatty liver, as I mentioned in my earlier slides, unless you're putting a person through a liver biopsy, this is more of a diagnosis of exclusion. You want to make sure you are ruling out other possible underlying liver diseases. One, because other liver diseases can mimic fatty liver and you don't want to miss a diagnosis that could potentially be, that needs to be treated with other management strategies to prevent progression of that disease. But also, as Dr. Yang said, if you have two concomitant conditions going on in the liver at the same time, it absolutely can increase the risk of disease progression and developing advanced fibrosis and cirrhosis.
Absolutely. The next question I have here is, so once you're diagnosed with fatty liver, what do you do next? What are the, like, besides obviously the diet, exercise to make sure to kind of reverse the course, but are there follow-ups that we're supposed to be doing? Like, how do we keep track of this?
So, I think when I do my initial evaluations for patients with NAFLD, I think it's really important to look at what is putting that person, what's really driving their fatty liver? Are they diabetic? What are their eating habits like? Are they sedentary? I think the pandemic has really hit a lot of people in a negative way. We were told to socially isolate. We were told not to go out, to go to crowded places. People stopped going to the gym. People stopped getting up and walking to go outside, to go to work. People were stuck in front of their desk at home all day long, staring at computer screens. And we just all had a very sedentary lifestyle. And some people, some people got very stressed, understandably so, and started stress eating. I was one of those people. I'm not going to deny that. And that combination, that perfect storm, really impacted people negatively. So I think we have to start thinking about, as Susie said, I think we don't want to just look at weight. It's not about those numbers. It's about, let's look at your lifestyle. Let's look at, are you having dessert every night at 9 p.m. before you jump into bed? Are you eating in front of the TV at 9 o'clock, right before you go to sleep? Are you spending most of your days literally just sitting in front of a computer screen, barely getting up to walk, except to meet your biologic needs of going to the bathroom or going to get a snack from the kitchen? Those are really the important things. And that's what I really try to focus on. In terms of follow-up visits, I think it also is very patient dependent also. And it also depends on looking at your liver enzymes. If your liver enzymes are elevated, I am going to follow you more closely than somebody who has normal liver enzymes. But then I'm also going to want to evaluate, do you have fibrosis in your liver? If I see scarring in the liver, I'm also going to want to follow you probably a little bit more frequently than somebody who doesn't have any scarring in the liver. I think it definitely becomes very personalized. And for all my patients, I absolutely always advocate having a nutrition consultation, because our nutritionists, they are so knowledgeable. They're so amazing. Every time I send a patient to them, I always get back amazing reviews. They certainly know more about nutrition than I do, and I go to them for advice. So I think having that combination of having a doctor following you, having a nutritionist help counsel you about, eating habits and having healthier eating choices, because sometimes we all need a snack, but let's have a healthier snack. I think that is all very important in terms of long-term follow-up and just sustaining a healthy lifestyle, that, to avoid that yo-yo dieting and all those extremes that we really want to avoid. This is really about making lifestyle changes for the rest of your life and not going on this fad diet that can only last you how many months. And yeah, you can lose all that weight and maybe all of that, some things will get better. But to sustain that is very, very difficult when you go to extremes. And I think this is where we start to see the rebounds and people start to gain weight and their sugars get high. And it does, unfortunately, mess with your overall metabolic health. I think I went on a complete rant. I don't know, Susie, if you want to add in on that.
No, you said my piece as well perfectly. I mean, that's all true. It's I just say in terms of next steps, there's a lot of individualization, customization that's happening. And that's both from the medical side and from, the diet side, is we can say, okay, here are the things we know to be true from research, from looking at studies. And then we're also looking at the person across the table or across the screen and saying, what's going on? It's rare that we just see one condition occurring without other things as part of a whole health picture. And so we're managing it all. And sometimes we're prioritizing one thing over another that's more urgent or whatever it is. So there's, much to discuss that's particular to you. That would be what I would say.
And one thing I want to add is that NAFLD is very different from some other metabolic conditions like high blood pressures or high cholesterol, where there are numbers that you could be, basically, if you go to your primary care doctor, they could check that and they could follow that pretty closely. Versus for this, you don't really detect it on a blood test. The only really good way of following it is really getting a FibroScan, like actually following the number of percentage of fat content in your liver. That's really the only way we could follow this disease at this moment, until you hit the stage of something terrible like end-stage liver disease. So it's, even though you don't get the constant feedback that you get from going to see your primary care doctor, you shouldn't really forget about this condition. Okay, let's change gears a little bit. How about some supplements? What are your thoughts about milk thistle or red yeast rice supplement? A lot of these supplements out there who are supposed to be helping fatty liver, but is it true? Is it bad? Thoughts?
Susie, you want to take this? You want me to? I can either way.
Yeah, I mean, I'm not aware of any really great data for either of those supplements as far as changing the course. So I don't include them as, part of a co-therapy. But Dr. Young, maybe you're aware of any more recent data, if anything's emerged.
No, so there's not great data on any supplements. And what I tell my patients that is like, in regards to milk thistle, it is used as an antidote in high IV doses for mushroom poisoning that causes liver failure. There's really no data on, especially in the much smaller pill dose form that you're buying in these natural therapy vitamin shops and whatnot. There's no data that this improves any type of liver disease or liver health. It's not going to harm you, at least health-wise. It does take money out of your pockets. I don't recommend it. I tell my patients, listen, if somebody's already on it, I don't necessarily say they should stop it. If they feel better on it, that's great. If they're not feeling any difference, then I say you should probably stop it, because it's just taking money out of your pockets. And then the what was the other one, Dr. Yang?
Red yeast
rice.
for
Oh
yeah,
yes,
red
the red yeast rice. Yeah, there's
Yeah.
really no data on that either. I really, and please, I cannot stress enough, please avoid any liver detoxifying cleansing agents. These herbal supplements, they are not FDA controlled. They can be contaminated with things that can potentially be dangerous to the liver, and really they have no benefit. So I would, and if you really feel strongly about something, then talk to your doctor about it before starting, because I've just seen too many bad outcomes and people just taking supplements that were touted as being liver cleansing or health cleansing and detoxifying. So I really don't recommend taking those things if you can avoid them.
Absolutely. I completely agree. And I think the most important thing is that nobody's looking at what's actually in them. Even though it says it's milk thistle on the bottle, you have no idea what's actually inside. No one's really controlling what the substance are you're ingesting, essentially. Okay, let me see where I have the next. Oh, any thoughts about certain medications that could potentially be damaging if you have fatty liver disease? For example, ibuprofen, Advil, NSAIDs, thoughts about Tylenol and things like that.
Okay, so that's a little bit of a loaded question. It really depends on your stage of liver disease, whether or not those medications are good for you. But what I will say is if you have underlying liver disease, it does not increase your risk of having a drug-induced liver injury, at least not what the data shows so far. But if you have significant advanced liver disease, and you do have an adverse reaction, if you do have a toxic liver event to it, you may have a more severe outcome because you have less liver reserve. And that really would depend more on your underlying liver disease. I think, so I would say, so for the most part, Tylenol, the ibuprofen, Motrin, Advil, those medications are safe as long as you stay within the prescribed safe doses and the recommendations.
Great. Let me see if and so once you have fatty liver damage and it's been a few years and you reversed it, are you still considered as having fatty liver? Or do you need to be followed?
So if you have no inflammation or scarring, if there is no fat in the liver, then no, you don't have fatty liver anymore.
And do you still need to be followed?
So I tell my patients, as long as, again, if there's really no evidence at all, they have normal liver tests, the imaging shows, we do our fiber scan or our VeloCure scan, there's no fibrosis, there's no steatosis, I tell them, great, you don't have to see me anymore. That's like the best thing ever, not having to see me. I don't take it personally. But what I tell my patients is like, listen, if you stay on course with what you're doing, with your healthy lifestyle, with staying physically active, you're not going to need me. But if anything changes, if at some point, whatever, we're all human, sometimes we hit a rough patch, sometimes we regress, sometimes things can happen, and sometimes there are genetic things that are just out of our control. If somebody suddenly develops type 2 diabetes, if somebody has high cholesterol because there's a strong genetic component and they're doing everything they can dietary-wise and physical activity-wise, if those things develop, then I say, you know what, come back for another evaluation because now you have a new comorbidity that puts you at risk for fatty liver.
I think we are at 7:30. Thank you, everybody, for joining in today. And as I said before, this is recorded. You'll get a link if you sign up for this. You'll get a link in about a week or so with the recording, and then you can also find all the webinars before or this one on our NYGA website. Thank you, everyone. Have a good night.
Good night.
Thank you. Good night.